Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear colleague, at the beginning I would like to thank Professor Dr. Nada Maher Dumyati and the organizing committee for the invitation, and I wish for them the best and the success of their conference. I hope that my presentation can present and explain my opinion about the gastrointestinal endoscopy in general, and especially the ERCP regarding the basics and the challenges. I think the medical basic science are essential for any medical approach. That's why I believe that endoscopy is not only a technique, it's knowledge and technique. And there is another factor that no one can teach it for other one. This is the ability or the attitude or what we call the talent. And because it's a gift from the gut, so no one can teach it for other one. But at least by knowledge and technique, you will be a competent endoscopist and you can make and take the proper decision, which is the main target in any maneuver you are doing. Historically, the ERCP started in 1968, and it was a diagnostic tool. And then, a few years later, after the first sphincterotomy was done, it became diagnostic and therapeutic. With the advancement of the image technique in the form of ultrasonography, CT, and MR, the ERCP technique became only therapeutic technique. But with the development of the cholangiopancreatoscopy, in conjunction with the ERCP, it returned back to be diagnostic and therapeutic, especially nowadays after the development of the single operator spyglass. Yet, these two modalities of endoscopy deal only with the ductal disease affecting the pancreatic biliary system. And the third brother of them, which is the AOS, can deal with the ductal disease and also with parenchymatous disease. So we can say that ERCP, in conjunction with cholangiopancreatoscopy, in conjunction with the AOS, can diagnose and treat almost most of the pancreatic biliary disease, whatever the site of that disease. Either it's endoluminal, as a stone or foreign body, neural, malignant or benign, and parenchymatous or extraductal disease. Before I do an ERCP for a patient, I follow my own 5 principles, and I hope it will help you. Number 1, I have to be sure about the indication to do that procedures, and this can be achieved by the clinical examination, laboratory test, and image technique, mostly MRCP. The second step, I have to look for the alternative that may be more suitable for the patients rather than the ERCP itself. The third step, I have to anticipate the complications. I have to prepare myself to deal with that complications if it occurs. I have to be sure about the availability of the intensive care unit, the availability of the pancreatic biliary surgeon, tools, drugs, everything can help me to deal with that complication. Number 4, I have to explain to my patients everything about his problem and how can I help him and what are the anticipated complications. And the patient should write down a consent about that. The last principle, I have to know when I have to stop when I am doing the procedures. If I face some difficulties that I cannot overcome it, and I have to start to think about other alternatives to help my patients. I think by following these principles, we'll avoid the nightmare of the complications of the ERCP. These complications could be in the form of post-ERCP pancreatitis, bleeding, perforation, cardiopulmonary events, and other miscellaneous complications. Most of the endoscopists believe that the failure of the technique is considered to be a complication. But from my opinion point of view, I don't think so, as we will see together later on in the presentation. So we have to differentiate between what's called complications and malpractice. Complications are medical problems that may occur either at the progression of disease or post-medical procedures, in spite of following the standard of care steps or the guidelines. On the other hand, the malpractice are also medical problems that may occur post-medical procedures without following the standard of care steps. And that's why it may expose us to this malpractice to medico-legal acquisition. So we should avoid as much as we can the complications, and we should avoid absolutely the malpractice to preserve the safety of the patients and the safety of the endoscopy team. And because of the safety, I named the ERCP in conjunction with the cholangiopancreatoscopy in conjunction with EOS, I named it DDS technique. The first D stand for diagnosis, the second D stand for drainage, which is the main target of the therapy, and the S stand for the safety of the patients and the safety of yourself and the safety of all the team doing that procedures. Some endoscopists believe that he is number one in the theater, he is number one in the endoscopy unit, and everyone in the team should obey his order. I don't think this is right, because from my opinion point of view, number one, he is everyone in his career. And we have to do these procedures under the concept of teamwork, acting together to help the patients. We have to respect the share of everyone in the unit. And we have to do it again under the concept of we rather than me, or we will be broken down like that picture. When I train one of my students or my trainee on the ERCP technique, just to simplify the technique, I classified it into 4 steps. Number 1, how to reach the papilla, because actually we are using side view duodenoscope, which is completely different from the direct upper or the direct lower colonoscopy. The second step, how to maintain position in front of the papilla, because the proper position will help you in cannulation, which is the crucial third step in ERCP. How to cannulate selectively either the common bile duct or the biliary duct according to the situation of the disease. The last step is the therapeutic options that can be concluded in ensuring fair drainage of the pancreatico-biliary system. All of these steps should be done by trial on base. If you please, avoid trial and errors, because trial and errors almost always ends by errors. And you can get that base from the medical basic science, as I said in the first slide. For example, in the third step, which is the crucial step of ERCP, selective cannulation of the pancreatico-biliary duct, you have to imagine the papilla looks like a clock. And if you would like to cannulate the biliary duct, you have to do it from 11 o'clock to 1 o'clock. On the other hand, if you would like to cannulate the pancreatic duct, you have to do it from 1 o'clock to 4 o'clock. This is basics, basic anatomy. You have to be aware enough about it. In spite of that, you may face some difficulties, and you have to evaluate the causes of these difficulties. It could be related to your experience, the experience of the assistants, the tool you are using, the technique you are using, abnormal anatomy either post-surgical or as a variant, or severity of the disease. All of this could be difficulties. One of these difficulties is the presence of diverticulum in the papilla, and the relationship between the papilla and the duodenal diverticulum could be in the form of periampullary diverticulum, juxtaampullary diverticulum, or intradiverticulum papilla. And this is considered to be one of the difficult situations during the selective cannulation. All of these difficulties has been discussed by different algorithms, different guidelines. Most of them considered 3 main factors: the number of trials, the durations of that trials, and how many times did you enter the pancreatic duct unintentionally. By evaluating these 3 factors, you can decide, is it difficult papilla or not? Should I do it conventionally, or I have to shift to another technique? On the other hand, you should be trained well. You should be aware enough about the tips and tricks by which you can overcome these difficulties. For example, using double guide wire technique, transpancreatic sphincterotomy, stenting the pancreatic duct, and then retry to cannulate the biliary duct, using hemoclap or forceps to protrude the papilla from the inside of the diverticulum, injecting some saline solution behind the papilla in the diverticulum to protrude. All of these are tips and tricks. You should be aware enough to overcome these difficulties. As I believe, the GIT is just a duct. It's a tube, starting by inlet, mouth, outlet, anus, connecting with it another tubal system, which is the pancreatic duct and the biliary duct. Treatment of any disease affecting this duct, targeting 2 main strategic targets. These are patent lumen of that duct, healthy functioning wall and parenchyma. And there is multiple tactics you can follow to achieve these strategic targets. Stone retrieval, balloon dilatation, sphincterotomy, stenting, or at least medical treatment to treat the inflammatory process and to keep the wall and the parenchyma healthy and functional. Return back to the failure, as I said before, I don't believe that failure is a complication, because failure with learning, you will reach the success. That's why you should have, before doing any technique, you should have multiple plans to prepare yourself. If you fail on one, you have to shift to the other one. For example, ask another expert, ask another specialty as BTD, AUS, and even surgery. By that, you can save your patients and you can help them. These are 4 statements from my experience, and I would like to ask you, if you accept, just remember it. It may help you in your career. The first statement, you should know when you have to stop and think about other alternatives. If you please, remember that. It's not a competition. It's not a challenge. It's not a contest. It's a trial to help your patient. The second statement, failure is better than catastrophe. It's not shame to say it's a difficult case. It's not shame to say, I need help. This is for the sake of your patient. Number 3, failure without complication is an acceptable outcome, regarding you are following the standard of care steps or the guidelines. But still, complications may occur, and you have to convince your patients about that. The last statement, you may not to do it from the start and to think about other alternatives that may be more suitable for the patients rather than the technique you want to do it. This is maybe better than failure and catastrophe. I think all of these statements considered to be a type of wisdom. All of these previous steps, you should do it very gently. As Gandhi said, in a gentle way, you can shake the world. The multidisciplinary team is the art of the medicine. And as I believe, it's not only multi-speciality, but it is also handling of multiple ideas within the same specialty. The most important member in this team, the patient himself, who should know everything about his disease, how can we help him, and even the complication that may occur. At the end, as I believe, the principle of all principles that we should follow it, trueness and honesty. Trueness and honesty with God, with yourself, and with the universe. Thank you very much.